Thank you very much, Christina, for coming along. I will just open our meeting by acknowledging the traditional custodians of the land where we are placed, the Wurundjeri people of the Woi Wurrung language group, and pay our sincere respects to the elders of the past who held their culture, elders of the present who strengthen their culture, and to all Aboriginal and Torres Strait Islander people that we engage with. And welcome to any Aboriginal and Torres Strait Islander people who are here in the meeting today. So, Knowledge Network, can I introduce to you Christina Wyatt from Occupational Therapy Australia? And she's going to, I did have it up in front of me and it's disappeared, talk to us about building capacity for people living with dementia, how to build good occupational therapy can benefit people living with dementia.
Yeah.
So thank you, Christina, for coming along.
My pleasure. Thanks for having me. So as I said, this presentation was one that I gave to Dementia Australia, and it's up on their website. And I've tailored it so that it's for people who don't have a clinical background or haven't necessarily worked in the allied health space. It's actually geared more for people who are living with dementia or their carers. So I'm hoping that I've pitched it right for this group of people in the room. And like I said, very happy to share the slides and pass it through your networks if that's of interest. I'm going to have a go at now presenting my screen, and hopefully you can see. I just want it to be presentation view though. Here we go. Let's do that. How's that now? Can you see the presenting slide only?
Yes.
Or can you see my notes? Oh, you can see my notes slide.
No.
That's really weird. Oh, you can't?
No.
Oh, fabulous. Okay, well, let's do it that way then. So just thank you again for inviting me to come along today and for the opportunity to talk to you a little bit about the role of the OT, in particular, how they might assist people living with dementia and their families and significant others. I would also like to start today by acknowledging the traditional custodians of the lands upon which I'm presenting from today, which is also the Wurundjeri people of the Woi Wurrung language group of the Kulin Nation, and pay my respects to their elders past, present and emerging, and extend that respect to any Aboriginal or Torres Strait Islander people with us today. So yes, you know my name, Christina Wyatt, and I am an OT. I've been an OT for 20-something years and have worked mostly in Australia, but also have done some work over in the UK. And currently I'm working as the professional practice advisor with an aged care focus within the Occupational Therapy Association. So OTA are the National Peak Professional Association for Occupational Therapists and Students in Australia. We're a member-based not-for-profit organisation, and we provide support and services to our members, enabling them to work across a wide range of practice areas and with a range of people as well. So today's session, I'm going to just talk through what dementia is, but I feel like I'm going to be telling you what you already know in some respects. So maybe I'll flick forward and just talk more to the sort of role of OT and the various areas of a person's life that we might go through. And then what I might do is just talk a bit about how currently you can access OT, the various funding schemes and pathways. And again, tell me if I'm telling you how to suck eggs, because I apologise if that's the case. But also we can think a little bit about what's coming down the line, and I haven't necessarily got slides for that, but I'm happy to just have a bit of a round table discussion around where support at home might take us insofar as allied health access and support, occupational therapy provision, service provision. So I'm going to scoop through some of these about what dementia is, because we all know what it is and the stages. I guess the point I'll make on this slide, if I may, is that really when it comes to the work that occupational therapists can do with people, we really want to be seeing them as early as possible in their diagnosis, because that early intervention can support with the implementation of some strategies that can actually help to reduce the impact and maybe slow the progression of certain symptoms with people. So really key to our work is as getting in as quickly as possible. And we're often able to see people even before they've had a formal diagnosis of dementia, when they're having that mild cognitive impairment presentation. And being occupational therapists in the community predominantly, that at that sort of earlier stage of presentation, we would be going into a person's home, and that opportunity to see them in their own setting is really a valuable insight, gives us a lot of information that, you know, the GP working with that person may not be privy to. People come to the GP clinic often in those early stages or in mild cognitive impairment presenting beautifully. You know, they're dressed very well, they've got lots of sort of indicators that they're holding things together quite well, they've come to the appointment on time, but it's coming into their home as an occupational therapist that we can look around and see how they move around their space, see how they might be processing the information that's available to them in their own home, and also just see signs of them maybe not holding things together all that well. You know, the fridge is always a window to a lot of interesting things and how people are managing, and having a little peek into that when you ask them to, you know, they usually offer for a cup of tea and I'll be, no, you take your time, go and make one. Seeing what's in that fridge and seeing what's growing sometimes in there is a window into how people might be managing or not managing based on their cognitive status. So I think that's just the point I probably want to make with that slide. So let's talk about the role of occupational therapists. So we work really to maximise a person's active enjoyment of life by identifying the barriers to participation and by building strategies to minimise any risks or impediments to participation. So to do this, we really look at a person holistically, and we think about what does their involvement in that task mean to them? What does the ability to do that task reflect their identity and their values? So it's more than just the doing and the outcome of that task. It's about all the elements of that task that make them who they are. So we then work on strategies to then achieve optimal health and well-being through the participation in those meaningful occupations of life. And I think occupation is the word that I want to just take a moment to look at, because it's in our title, but it actually is very difficult for a lot of people to understand what that means, because in the sort of common vernacular, occupation means work, doesn't it? You know, it's what we do for our jobs. But actually, in the context of occupational therapy, occupation to us actually means activities that are meaningful and purposeful. So the things we do to care for ourselves, for others, to be the person we want to be. And so that's really what we're talking about when it comes to occupational therapy. We're looking at all those things that we do to be who we are, all the things we do to create a meaningful life, and all the things we do so we can engage with wider society and culture. And it's these meaningful activities might be the daily routines that we talk about as far as taking care of oneself or others, so showering, dressing, making a meal, right through to things that we do to engage socially or participate in hobbies or leisure pursuits. So it's the range of things that we all participate in our everyday life. So for people living with dementia, an occupational therapist can support with maintaining the independence and quality life for as long as possible. And we know that this is a degenerative condition, so there is a trajectory towards people losing function to the point of needing full support and reliance on others. So we do what we can with the strengths and with the capacity that we have available. So we are very much a strengths-based approach. We look at what a person's skills and knowledge and abilities still allow them to do, and then we work from there, and we foster on those functional skills that we still have available to us. We also look at the personal goals, abilities and motivations. So that's that holistic perspective that we bring. And then we break down those tasks that a person might have identified to fully appreciate what that task might involve and require of someone. And then we consider how other factors might come to play in supporting or hindering that person's performance. So it might be the environment, it might be stimuli in that environment, or it might be the physical environment. It also is about their occupational goals. So, you know, they might no longer want to do the task the way they used to do it, but they still want to do it in a certain way that allows them to be part of that task. So making the Sunday lunch that everybody used to come together to have, you might not be able to do it in that full way that you might have many years ago, but you still want to have a role to play and participate in that. So we adjust those goals around what that person's identified as important for them. And when we talk about environment, we're talking about all the ways and the places that a person might do their activities of daily living. So obviously home is a very important environment, but, you know, people are still working. Maybe if they're a younger onset dementia presentation, there's social and community settings where people might be engaging. And so what are the factors that those environments might bring to support or hinder the participation in the meaningful occupation? So we, as I mentioned earlier, we take a holistic approach to the person and to the tasks that are important to them. And we do this by fully exploring the person, the environment, and their occupations or their everyday important activities that they want to participate in. And it's really, if you think about this, it's not perhaps presented in the way that I would normally think about it, but if we think about those three sections as a Venn diagram and they intersect in the middle, then we would have occupational performance and participation right in the centre. Because if we get the person needs met, and if we get the occupational needs met, and we get the environmental factors met, then we've met the occupational performance and participation in the very centre. So through these parameters, we can really appreciate all the facets that make up an individual and then all the factors that might influence their ability to do what's important for them. And when we're talking about people living with dementia, this will be a constant and an evolving review and evaluation, because as we know, symptoms will change, or the complexity and range of symptoms will evolve with a person's diagnosis. So we will continually assess and review how these parameters work together to support and to hinder a person's occupational performance. So I'm going to take you now through some key areas of a person's life and then think about what the role of an occupational therapist might be in supporting someone in those areas who might be living with dementia. So we have daily activities of living, and I think everyone knows that language. It's become pretty common language now, but that's really is the things that we do every day to support ourselves, to make ourselves healthy, safe, comfortable, making a meal, showering and dressing ourselves, getting in and out of bed and on and off the toilet, those sorts of tasks that we might need to do on a daily basis. We might use a range of strategies to support someone with their ongoing participation in these daily activities. And we might look at also revisiting how a person does those tasks. So we look at environmental factors. So maybe what's the environment doing to make it easier or harder for that person as their progression of dementia continues? Can we bring environmental changes in that might support that task? And I'm thinking things like, you know, how do we use the bathroom as we get more unstable on our feet? Can we do something to make that space a bit safer by putting in grab rails or changing the layout to make it safer to use the shower or to use the toilet? We also look at how the person does that task. So what are the elements that might be really difficult for them to do to complete that task in its entirety? And how might we be able to adapt or retrain to be able to still do the task, but not the way they might have all in the past? So I think about often meal prep as one of those examples. People might have always stood at the kitchen and for hours cooked over a stove and stood to chop all their veggies and done all of that in a much more upright position. And that might become harder as a person's physical capacity changes, perhaps with or without dementia in place. And so we would look at, well, what might be a different way of doing that so that you could still cook the meal but not be so exhausted by that task of standing. You know, could we bring it to the dinner dining table and do it there? Do we want to use a standing, like a bench or trolley, or it's some different type of aid to make that task a little bit more effective? Or even, do we get rid of the chopping up of the veggies and buy them ready chopped in the freezer? Like, how can we adapt that task and think about ways to simplify it and make it a little easier, but not take that task away from that person? We also work with the family and the significant others and the carers who might be working with that person. We might also train them on how to better approach activities so that then we can work with the strengths that might still be in play and let that person living with dementia still have a role and participate in the activities that are important to them, but also then have that assistance from the carers that complement and support that. So that's really restorative care at its core, you know, thinking about not taking away and doing for, but doing with, so allowing a person to still have a role and a place in that task. And that by taking away the activity from that person, we're actually kind of almost increasing the likelihood of deterioration, because we're taking away opportunities for cognitive and physical engagement and stimulation. And as you would expect, small aids and equipment might be a good way of supporting people with these tasks. And we, as I said earlier, we might modify the environment. So I've talked to environment a little in the earlier slide, but environment is really important. And as I said, environment isn't just the home. It can be all the different places that a person might be engaging in their meaningful activities. So it could be the local church. It could be the local community services that they engage with. It could be their friend's house or their daughter's house that they go to on a Sunday for lunch. So we want to make sure that we support people to engage in their environments no matter what they are, but also that the environments don't hinder and limit their ability to do the things that are important for them. We also know with dementia, sometimes, you know, the ability to then understand and process what's around them, that information available to them. So where they remember that they keep their cups and their tea bags in the kitchen starts to become harder. No matter how many years they might have lived in that home and how familiar they are with that space, that environment can become quite foreign to someone. And so there's really simple and quite straightforward strategies that occupational therapists can bring in to support people to still use their environments and the places that they're familiar with, even when they start to become less familiar. So signage is a great example. Also just taking the doors off cupboards so that people can see into them and see what they're looking for at a glance, rather than, you know, trying to remember where they might have left that stuff. There's simple things that we can do to modify the environment and keep people moving and using their home. Also signage, and I think I mentioned signage, but colouring of areas. So I think colour is really important. You know, more and more home designs are becoming quite sort of singular colours and quite bland colours. And so things like light switches are built to be kind of blended into the colour of the wall. You know, we want them to almost be hidden in some respects to help with our sort of new perspectives around aesthetics in homes. But that can make it really hard for people who might be having some of those visual and perception changes that come with dementia. So even just having some coloured tape around light switching or around door frames, so people know that that door frame is the door to the toilet, not the door to the walk-in wardrobe in my bedroom, can be a really effective way of modifying the environment very simply. We know cognition is a key element of the dementia prognosis and change. I think the thing that people don't often know about occupational therapists is that we actually have expertise in assessing and identifying cognitive change. So we can perform a number of cognitive standardised and non-standardised assessments to understand exactly how a person's cognitive capacity is presenting. We also have a lot of knowledge around functional cognition, so the ability to understand how those cognitive changes are actually being displayed in function and in a person's performance, and then also convertly to look at how performance might be informing where the capacity and the changes in cognition might be. And that information can be really helpful, particularly in the early stages before a diagnosis, because you might be saying, well, these changes are sort of age related, or these changes might be because this person's on this medication or on that medication. But actually, when you standardise it and you look at it from an assessment perspective and you use a functional cognitive lens, you might be able to see a pattern that suggests something more than just what aging or a medication change might be influencing. So I wanted to just raise that as a particularly undervalued role of an occupational therapist in this space in particular. When it comes to strategies and ways that we can support people with their cognitive changes, it really can vary, and it depends, I guess, on where they are in their stages of progression. So people might be having very mild changes, and so small strategies like using calendars, diaries, building daily routines, they can be quite useful in those early stages. And then as we see a more kind of moderate to severe progression, we might be using more structured and more integrated systems like digitized diaries or set alarms with, you know, your Google Homes and your Alexas that might be able to sort of work autonomously of the person being able to initiate that engagement with that device. So that's kind of the things that we might be using with people in the home, but certainly we can also work with families, significant others, carers, to think about how they can also make the use of those sorts of cognitive strategies and support people with their orientation to day and time, because that's often a big change in dementia that we see, particularly in the earlier and the moderate stages. I also wanted to just raise, when it comes to cognitive strategies, there is an approach that we are often looking at, which is a rehabilitative approach. And that's why it's important to think about an early intervention model, because if we can bring some of those strategies in and actually provide those rehabilitative approaches, we can in many ways, I guess, influence the trajectory of some of those changes and how a person lives with those changes as they progress. The earlier we can bring those strategies and the rehabilitative approach in, the more likely they can live well for longer with their dementia and perhaps stay at home, and the burden of care on carers might be somewhat reduced as well. Functional mobility, I guess what I mean by that is how people might move to do their everyday tasks. So getting on and off furniture, navigating steps and stairs, just making their way through the environment that they're using. We often see that is a change of people living with dementia. It's not with everyone, and it often can be seen more in that sort of moderate to severe stages of presentation, but certainly can really negatively impact someone's ability to participate in their activities of daily living and meaningful activities. So what we're coming in to often look at how they can do those tasks with the use of equipment, with the use of environmental changes, or even support carers or family who might be assisting that person to do those tasks, to do it in a way where they're safe, and also the family who are supporting them or the carers are supporting them are doing it safely as well. So manual handling or activity retraining. We also know that falls is quite prevalent in this community of people because of these functional mobility and physical changes. And so we can also look at specifically targeted strategies that will mitigate the risk of falls, particularly in the home. There was an excellent systematic review that was done through the Cochrane Library about 1.5 years ago that found that all the modalities that are used to prevent falls in the home for people with a high risk of falls, home hazard reduction conducted by an occupational therapist was the highest quality outcome and the highest quality intervention. And that's beyond even like strength and balance exercise programs from physios and all those various other modalities, which are absolutely important, and we should be able to support people to have access to them. But they weren't even identified through that systematic review as high quality in their impact as a home hazard reduction approach in by an occupational therapist. So I want to encourage people to think ahead, be proactive, and to sort of bring occupational therapists in at the very early signs of a fall. So when they're having maybe a near miss or a trip, or they're seeing some deterioration or slowing down of their mobility and of their functional transfers, let's think about what that home hazard mitigation can be. I'm happy to have questions if anyone's got any for me whilst we're going, or we can take them at the end. I'm open to both, so let me know what works. Oh, here we go. Question.
Hello, Christina. Thank you for your sharing.
No problem.
I just, want to ask, your triangle, the person, environment, and occupation. And then now occupation, like someone, with dementia, like they already, stop working, no
Yes.
job. So the meaning of occupation from my, sense, maybe it is bigger, not limited, to your career or job or whatever.
Absolutely.
So can you explain more about the terms, occupation?
Yeah, absolutely. So no, you're absolutely right. So for us as occupational therapists, we're talking about occupation as being anything that you do that's meaningful or purposeful to you. So your everyday activities, the things that make you who you are, and the things that you have to do to be able to be safe, healthy, well, feel quality of life, feel value, feel purpose. So definitely not just your paid vocational roles. Absolutely. That is one element of a person's life, but it's not the only part that we would look at. We'd look at all the elements that make up a person. So, leisure and hobby activities are often very much relegated as less important by the health systems and by the disability systems that we might be working under. It's often about just mitigating the impacts of that injury on the ability to get a person to, care for themselves or to do their everyday tasks. But we're very much looking at all the things that are important to a person. And that could include things like, I love to go dancing and I can't do that anymore. So what can be done to help me keep that occupation of dancing in my life? Is it a change to the way you get to the task, like getting there? Is it the driving there? Is it the people that you can do it with? They're no longer available. Is it that you just can't physically do it the way you used to? So do we need to adjust the task and think about how you can still participate but without maybe the risk of falling or injuring or whatever it is might be. So you're absolutely right. Occupation is not paid work only. No. I feel like we need a rebrand for occupational therapists. I feel like we need a new name. I'm not sure. So I'm open to suggestions. I don't know if my CEO would be up for that, but it's a real problem because everyone looks at us and just goes, oh, you're all about just people work, the work that people do. And it's like, we're not. We're bigger than that. But thank you for clarifying.
Thanks, Christina.
No problem. Okay, so the other parts that we'd work with a person on are really about their connections with others. So it's really important that we maintain relationships with family, friends, colleagues, and connections to the community of interest, particularly as a person's cognitive changes are starting to become more severe with their dementia. You know, their ability to have familiar people around them and familiar opportunities to engage can actually be a preventive or a protective factor for people with dementia. So we want to make sure that we continue to support those activities and those engagement opportunities. And where necessary, and I think it alludes to the example I gave earlier, if that task is no longer something a person can do safely or for whatever reason can't participate in any longer, what can we bring in as opportunities to continue to support engagement with others that would meet their functional needs and their values and their meaningful engagement goals? So, you know, dancing was one example I gave. I had a client who really loved fishing. All he ever wanted to do was be out on the jetty and fishing. But, you know, his ability to then take himself out there to do that became harder as his dementia progressed. He wasn't able to drive. So, you know, what we did was we connected him with the local day links or the sort of driving service, and we were able to connect him with a person who could take him there. We also had volunteers that would then sometimes come and accompany him. But, you know, that was probably the biggest barrier for him, because once he was there and he was set up, all that past memory and knowledge of how to, you know, put the bait on the hook and cast it and be a part of that was all still there. And we want to really retain that ability to bring back those skills and to use them on a frequent basis, because that is, as I said, quite protective in many respects. We can also just look at ways to keep people connected through other means that might not be something that they have familiarity with. So I'm thinking about, you know, the last handful of years that we've lived through where we've been quite disconnected because of pandemics and the ability to stay connected through digital and virtual formats. You know, that may not be a skill set that people living in older age with dementia might have. So what can we do to bring those skills to them in a way that they can use that to connect with their family, with their friends, with just the broader world? And as I've alluded to, recreation and leisure is so important, and we really need to make sure that people still have access to those things that are giving them that sort of level of social and leisure and recreational engagement, because certainly that is a key element of how we have quality of life. So we'll often work with people who are living with dementia and their families and carers to ensure that they can maintain those pursuits, or we might look at strategies to adapt that task so they can continue to participate, but maybe not the way they used to, or we might look at whole new opportunities that people might have available to them locally, which still speak to their meaningful and purposeful goals and values. Now, care is absolutely an essential part of all of this, and people who provide care, so families, friends, neighbours, all the people that might be part of that support network, we are absolutely working collaboratively with them, and we work to support them in a variety of ways. So really, one of the key ways is around supporting their wellbeing. We recognise the significant burden that can come from supporting someone living with dementia, and so we often are providing strategies around stress management or mindfulness or other ways to support them through respite engagement and other services that can come in and support them to continue and sustain their role as a carer. And then we also look at their role in caring and think about their safety and their ability to do that task, because often as we're seeing older people getting a dementia diagnosis and their significant others also being quite older and elderly, their ability to do some of that physical activity required of caring can be quite limited, and we don't want them to be injured or hurt. So we might look at how we can adjust the task so that they're not in any way compromised when they're supporting that person in the caring role. We might look at manual handling techniques or use of equipment to make that task easier and safer for the carers who are assisting. We also might link them with specialist carer support agencies. and counselling services. So there's a range of ways that we might support the carers who are working with people living with dementia. And it's also important to note that we deliver our services best when we're part of a multidisciplinary approach. So we are able to support people in a way that complements the work we do, because we can't, obviously, as one discipline, address all the needs of an individual, and we shouldn't be expected to. If we work into our scope, we wouldn't. So we rely on other clinicians to come and complement the work we do. And when we do that in a multidisciplinary model, and we have that supported structure around us to do so case conferencing or linking with GPs and other health professionals who might be involved in the care of the older person or person living with dementia, then we can actually do a more effective and more deliberate and targeted way of supporting that person. So we're often sometimes one of the first people that might be brought in as part of the allied health team. And, as I said earlier, have a bit of a lens in and a bit of insight that come from coming into a person's home that might suggest, oh, these are other disciplines and these are other services that you might benefit from. And we can sort of facilitate those referrals out to that multidisciplinary network. So I think often it's just important to have at least one or two key professionals coming in to support that individual. And if they're well connected and they've got the right resourcing, they should be able to bring then the rest of the professions that are needed to support the identified needs for that person. So how might we go about getting access to an occupational therapist? There's a number of ways that people can access occupational therapy, and so I'm going to race through those now. For those who are over 65, as we all just spoke about at the beginning of this meeting, we have the Commonwealth funded aged care systems, and the portal and the pathway to access that is our My Aged Care. We get the phone triage that then triggers a referral onto an assessment service. The assessment service will do the comprehensive assessment of needs, and that will generate then currently a package level or a referral to Commonwealth Home Support Program. And both those services, both those Commonwealth funded programs for home-based aged care, have the ability to bring in occupational therapy and other allied health services. So Commonwealth Home Support Programs tend to be grant funded currently, and so they have sometimes in-house allied health teams that allow for the access to those services, and occupational therapy is often there. And then home care packages usually being brokered by individual providers, they can bring in the services identified by the care plan and by the needs of that individual. And a lot of allied health professionals, including OTs, work sole trading in that space, so we can be brought in privately if you're not with an allied health team in-house. So again, I feel like I'm telling you how to suck eggs, so I'll move on. I want to just flag GPs and in particular chronic disease management plans. I know there's a lot of change that's currently happening at the moment with how those are assessed for and then administered by GPs. But one of the things we find with these is that, yes, they're an opportunity to get access to allied health because you get your 5 allied health sessions under a CDM. But for occupational therapists who are wanting to do really quite detailed and comprehensive work with a person and really get into and understand the needs they have, that model doesn't always work for us. So it's not usually well utilised by occupational therapists in this space. Having said that, though, and I was at the Positive Ageing Summit last week, I don't know if any of you were there, but it was great to hear some of the GPs in the audience talking about how they really want to start using the case conferencing elements of the CDM more, and to use that to bring the various allied health and other professionals involved in the care of individuals. And so I think there's some redeeming features about how that model works, and the ability to charge for that as a line item in itself without it being direct care for that individual. So there are lots of good factors and lots of good features, but I do think maybe not the most appropriate or well utilised pathway to accessing occupational therapy, but worth knowing. We also have Veterans Affairs, and there are people who can access allied health through their eligibility, if they meet the eligibility through their veterans card. So I think gold card holders should be able to have full access to allied health and to then the equipment and modifications that are available through the WRAP scheme on the DVA. And I have a feeling from memory that also white card holders, so they might be the widows or the widowers of veterans, they can also have access to some allied health services as well. And I wanted to just highlight that in recent times, they've actually allowed for allied health to also be funded through DVA into residential aged care. So if people are living in residential aged care, you can access your allied health through your DVA funding. The only caveat is that you need to make sure it's not a duplication of something that you're getting through the ANAC funding in residential aged care. So, and how you know that is so grey. I get questions from members all the time. You know, I've been brought in by DVA, but I don't want to be audited to be seen to be duplicating something that should be funded through ANAC. It's very grey. So my understanding from a recent meeting with the, I think it was the department, was that they are looking at putting out some more structured resourcing that really explains how that might look and when you might bring in DVA in those situations and those settings, and complement the work that's been delivered under the ANAC funding. And then obviously there's private health insurance, and some people may have coverage under those funds that allow them to be able to access occupational therapy or health and wellbeing programs that have occupational therapists within them. So it's important people make sure they use them. And I think somebody gave some statistic to me a week or so ago that said that a huge proportion of people are living in residential aged care still with private health insurance, and probably not aware of how they can use that to support access to a range of services, including occupational therapy. So I think we want to just remind people that if they still hold private health coverage, that they want to see whether there's any capacity through their coverage and their extras to have access to occupational therapy services. And then also conversely, people can go directly and purchase private occupational therapy services without using funds from health insurance or any other services. So that is becoming more increasingly utilised across this community of people, because, you know, the delays to getting assessment through My Aged Care and through the assessment workforce, the delays to getting a package, you know, it's quite significant. People want services now. So, you know, they can access us privately through the private OT network. Sorry, I'm going to take a step back. Just one last thing I wanted to say about specialist services is that OTs also are found in a lot of specialist services that people with dementia might be using or might be eligible for. So I'm thinking about movement disorder clinics. I'm thinking about pain clinics. I'm thinking about sort of all those specialist services that people might be needing because of their presenting needs. They do usually have some level of occupational therapy support in them. So it's important to just chat with your GP or have those discussions with the broader network of health professionals involved to see if those referrals can be made and whether that might be an access point for occupational therapy. I think we all know about these services, so I probably don't need to tell you all about them. But I will highlight here on the top of the screen, there is our Find OT. I actually think that hyperlink might not be current, but it should still allow you to get to where you can find the search engine, which is on our main occupational therapy website. We've just had an upgrade to our website, so that's why I'm wondering if it's no longer current, but it should be. It allows you to search by locality or postcode, and it also allows you to search by types of service that you might need. So if you're looking for modifications, you can look for people who might have experience as an occupational therapist with home mods or with equipment or with dementia. I think we have got that as one of our practice areas that you can search under. So just important, if people are looking for private clinicians or wanting to know who to refer on to, that's one place to start looking. As I said, so many different places and spaces where you might get access to an occupational therapist. Not all of them will be the right fit. You know, as I mentioned, CDMs or Medicare may not be the right approach. It might be a good starting point, but then you might need to move a person on to a different approach to give them the more kind of intensive and comprehensive OT that they might be needing. So it's a matter of just doing a bit of that jiggling and knowing how those different schemes work and how to, you know, determine eligibility and access. And I know you're all familiar with them. I might take a moment now to just think about, get my crystal ball out in front of me and think about support at home. We know it's not happening until 1 November now, but it will change the way that people access allied health. And I have some concerns about what that might look like. And I thought I might take the opportunity to just flag a few of them and just see how people are anticipating that in their own spaces and places. So I guess it starts with making sure that the assessors who look at the needs of that individual fully appreciate and understand the cognitive and the physical and other symptoms that are coming as a result of the dementia diagnosis. And if a person is, as I said earlier, mild cognitive dementia, hasn't yet got a mild cognitive impairment, hasn't got a dementia diagnosis. Are those assessors equipped to identify those factors and to think about that early intervention? I'm not so sure, if I'm honest. We do have a proportion of that assessor workforce who are clinicians, and I would like to think that they may be in a position to sort of see those flags and maybe anticipate that and think about integrating that into the care planning and the classification that comes from the assessment. But the vast majority of assessors are non-clinicians, and for what it's worth, I've done my best to advocate as much as I possibly can to the powers that be that we really need to build excellent guidance materials, excellent training modules for the non-clinician assessment workforce to fully appreciate how a presentation might warrant then a referral to a key allied health professional, and to get that to happen right at the very beginning, so that then we're not having a lot of people sitting and not getting the services they need in a timely manner. The other thing I have concerns around with the assessment pathway is then the reassessments that are needed to then bring a conversion to the care plan or support plan to allow for allied health to be brought in if it hasn't yet been identified at the beginning when the first assessment was done. I think many of you are working in the space know that we've got huge wait lists for people to be just assessed, let alone reassessed. And I just worry that if we don't get that first assessment and support plan correct and accurate, then we're going to just be, kicking the can down the road and keep pushing people down and away further from getting the right services when they need them. And to a certain extent, that extends to AT and HomeWatts funding, because that will be determined by the outcome of that assessment. And if they're non-clinician assessors and they don't really know how to convert that information from the assessment into the right tier of funding for equipment or for HomeWatts, then, people will be delayed in having access to the things that are important to them. So that's the entry point. It's the internal machinations that we're also really scratching our head about. I don't know how allocation to allied health funding in a person's care plan budget will mean that they get the right mix of clinicians. If you've got an excellent provider who really understands the roles of those different allied health professionals and why they need to be brought in and how to bring them in, fabulous. But I suspect there's going to be a lot of providers who may not have that knowledge because they don't have in-house clinicians or don't have privy to access to speak to a lot of clinicians to understand when to bring them in and how to. So how to use that in the allied health funding in the budget, ongoing budget, I'm worried about. I haven't yet, and I'm going to be full disclosure, yet read the clinical guidelines that have just been released for the restorative care pathway. I think that's going to be our main access point to allied health services. I was able to, at the summit last week, ask Claire Goff, who is one of the academics who are involved in the advisory group for the development of those clinical guidelines, have you thought about people with a cognitive disability needing rehabilitation? Because I worry that the restorative care pathway is really physical focused, and they're going to be wanting to stop people from falling, and they want to see people getting up on their feet more and doing all of that. But as we know, there's a lot of rehabilitative approaches that are really successful for people living with dementia or mild cognitive impairment in the home. The COPE program is one fabulous example. And so we want to make sure that that restorative care pathway and the funding available to that also supports people to have access to those types of rehabilitation as well, and support their behavioural and psychological symptom changes that might be coming as well from their dementia diagnosis. Claire assures me that they have absolutely thought about that, but I haven't yet read the details, so I want to hold comment on that just yet. So that's probably enough for me. I think, I've got probably 10 more minutes. If there's any chat or any questions, I'm happy to go for it, Rachel.
Yeah, I just wanted to ask you about the COPE program. Do you have?
Yeah.
I did some training on it a little while ago when it was just kind of starting. So I just want to know. I'm an RN. What if you have many OTs that are part of that program, and if you're finding more and more are doing that, or sort of?
Absolutely, yeah. So I can speak a bit to what OTA is doing in that space. We've partnered with Kate Laver, who was one of the academics who converted the COPE into the Australian context, and her colleagues, and they continue to provide COPE training through OTA's CPD program probably 3 to 4 times a year. So we have, and they sell out. They are so well received and so in high demand. COPE are really quite an amazing program and quite an amazing format. And I'm preaching probably to the converted here, but it's not something I think generally people are aware of or know about. And so, you know, whatever your network can do to help promote that particular approach, particularly for people who are in that sort of early or mild presentation, because it's that rehabilitative and those strategies that I mentioned earlier, that when you bring them in and you embed them for the person living with dementia and for the people who are working and supporting them, then you actually can really do some great improvement on slowing the progression and slowing the impact of the dementia on their everyday life, quality of life, all that sort of thing. So
yeah, absolutely. And how are you finding most people are funded to do it?
Privately.
Yeah, that's what I thought. Yeah.
Yeah.
Okay.
I think there's a real shift and people are wanting to embed and skill themselves up in this space. So OTA have actually made a real commitment over the last 12 months, 18 months to really up the number of CPD offerings we have with a specific focus on dementia. We've run some really successful and fantastic what we call practice spotlights. They're like a 90-minute snapshot session, really practical, tangible skills that people can take back into their like work life and their practice straight away. And we've run a couple on functional cognition, so starting to really build the skills of clinicians who have an awareness and a knowledge around dementia, but maybe aren't bringing that functional cognitive lens to their assessment and then their intervention planning. So we've done 2 sessions unpacking that, and we've got a third on the way, which is going to look specifically at how you can translate your functional cognitive assessment and intervention findings to support the carers. So how do you then teach the carers based on what you're observing to support them in their role and give this the person living with dementia the opportunity to have that information reinforced on a regular basis? So that's something that's coming. We also have did a 2-day workshop called Untangling Dementia back in March in our first CPD Empower event, which is an event where we host a number of different CPD events in one location. So it's a great networking opportunity. And that was so well received. We had 30-something people attend that workshop over 2 days. And we're planning on rolling that out over other states and territories so that people can get an opportunity to do that, because it's an in-person workshop. We're also partnering with some clinicians who have done the TEPA Snow positive approach to care training, and we're going to be rolling out some introductory sessions. So not the full training, but certainly some sessions that will bring the key elements of that approach to clinicians to again take to their practice, and then also gives them a taste of whether then they want to take that next step and invest in doing the full training program. And we also did some work with Dementia Support Australia, and we ran 3 joint webinars with them looking at changed behaviour. So and how clinicians like occupational therapists, with our approach, our sensory focus and our ability to conduct sensory assessments and do sensory profiling and then convert that into behaviour support planning, how we can do that better. And then also what environmental strategies might we be able to adopt to support and complement those behaviour support plans. So we've really started to up the ante when it comes to building the capacity of our workforce, in particular in this area of dementia.
Thanks very much, Tal.
And Lucy? We can't hear you.
It would help if I muted myself. I hope it's going to be a quick one, but it was in relation to the support at home program. My understanding was that allied health, including OT and nursing and physio and all that kind of stuff, is not subject to co-contribution by anybody.
That's right.
So that would be completely free. So does that still mean that it would still need to be part of that assessment and care plan? So if that isn't considered to begin with, for whatever reason, because like you, we have heard of assessments not being done in the way that they should be. But, you know, even though they are available free to people, they still are subject to this assessment and to this budget allocation, whatever that budget allocation is. And does it vary from which level they're at? Even though it's free, does somebody on level 2 would have a different budget to somebody at level 8?
Yeah, it's a really good question. So I don't think there's any actual ring fencing of money that goes towards allied health. Once upon a time, when we started the discussions with the support at home implementation team, and I'm talking like 3 years ago, there was some discussion around ring fencing that money for allied health so that it couldn't be taken off to pay for Betty's transport or for her showering or whatever.
Right.
And then they've really walked back on that and decided not to do that. So it will be allocated like a bucket of money to cover all the services that might be needed. It's going to be integrated into that bucket that gets given to the provider. So it's at the discretion of the provider really to look at what's the outcomes of that particular assessment, to see if that was recommended as an element and why then that influenced maybe the classification level that person was allocated, and then make those arrangements with the appropriate health professionals to do what they feel is needed. And I think that's where that meeting with that individual and meeting with their carers and their significant others is going to be really important, because if you understand that actually my goals are around being able to go back to fishing, yes, there's going to be elements around, okay, how do we get you dressed and washed and cared for in the morning, but also what are your vocational and occupational roles that we can bring an occupational therapist in to look at to support you with that task. So, and I think I would implore everyone to just try and be as restorative in your thinking as possible. Like, I know there's a real, I guess, like a bit of a historical approach to bringing in services to take that support and to give that support to that individual. But we know that that actually can sometimes work against their ability to retain and maintain their function. And so if that person's saying, look, I'm really struggling to shower, you know, it might seem easy enough to say, well, we'll bring somebody in to do it 3 times a week with you. But maybe the alternative approach might be, well, let's look at putting you through the restorative care pathway, or let's get an OT and a physio in and see what we can do to get you to do that task as much as you possibly can, with the support of whoever's available, so that you can stay active and use that function. I often look at people who have gone into resi care and I think, what a shame that you're not able to get up and make yourself your own tea or iron or fold your laundry or go to the front letterbox and pick up the letters, because it's all those little bits of incidental movement and engagement with others that might come from those activities that actually keeps us living for longer and living well for longer, and particularly people with dementia. And the minute you take those tasks away from them, you're just, you know, I don't know, I think you're disabling people, if I'm honest with you.
I agree. Yeah. Thank you.
Yeah,
thanks.
I'm so confused by what's going to happen.
As you were talking and you talked about the restorative care plan, which as I understand it, it's an addition to the package. So again, it has to be approved, assessed, and approved. So then it's like, oh, okay, we can grab this extra bit, you know, because we can put in the. And it's just a minefield, really is a minefield.
It is. Yeah. And the thing about restorative care, which I understand, is that if you're assessed by the IAT, like entry into the aged care system, as going, we're going to send you straight to restorative care, that's one pathway, but you can't have ongoing supports alongside you if you come in that way. Whereas if you come in and you go, we've got an ongoing budget allocated, and in the course of delivering that, we recognise you would benefit from restorative care, you can retain your ongoing budget whilst going into the additional 6,000 restorative care budget. So that can work together in that way, not the other way.
So somebody has to be on the board to say that's the way you should go, not that way.
This is the thing. I don't know how anyone could possibly know that or navigate that. You just
Wow.
Tricky. So I don't want to end on a doom and gloom. I think I want to say yay to giving us some breathing space. Let's hope that the next few months give us the opportunity to ask those questions and to prosecute some examples, some real life scenarios, and say how can that look in reality? Because I think that's the bit of work that hasn't yet been done, if I'm honest with you. They haven't tested any of this on any of us who are on the ground going, well, that's not going to work because we can't do it that way, or we don't have the staff to do that, or this is not going to happen. So I think this is the opportunity we have with this bit of time.
Yeah. Thank you. It's been really great. Yeah.
Oh, I hope it has. Thank you.
Yeah.
Thank you. So were there any other questions for Christina? I just wanted to say that the colour contrast of the light switches and, you know, the minimalist environments now, that sort of thing really resonates here. We've got very white bathrooms with, and they've always had very black toilet seats, so that, you know, the toilet seat is. Do you know how hard it is these days to find a black. toilet seat to replace them?
Yes.
I found them at Reese's.
Yes.
And I bought 5. People said, "Why have you got toilet seats in your cupboard?"
Yeah, yes, yes.
Because they're going to
when
fail.
you need them, you can't find them. Yes, absolutely. And I love that, you know, with our sort of, I don't know, love for the block and all these other new TV shows that are all about, you know, home renovations, that actually we're seeing contrast and colour being used a little bit more. And, you know, so grab rails or towel rails that are black. It's just, it's commonplace now. You go to Bunnings and you can find them. It's fabulous. And so that's the sort of thing we want. We want that universality of access to be just part of everyday life, because if it helps one person, it'll help a whole range of other people, I'm sure.
Absolutely. Yeah. Well, thank you very much. That was really, really interesting, very informative. The hour went very quickly. I'm sure people will think of more questions once we hang up the call, but really appreciate you coming along today. I'll let everybody know when that recording is up. And
I'll send you the PDF of the slides if you like.
Thank you very much. And then I'll distribute that as well. Thank you.
Yeah, no problem.
All right. Thanks, everybody. Nice to see you.
Thanks,
everyone.
Thanks, Christina.
Bye-bye.
Bye.